implementing changes to stroke protocols in order to facilitate decreased door-to-CT timing in rural community hospital. In patients suspected of stroke, how do the benefits of immediate computed tomography or CT scan upon arrival compare within the 25-minute standard door-to-CT time, create for success in treatment of stroke within the first hour of treatment? So, in 1996, tissue plasminogen activator, or TPA, was approved by the FDA for treatment of acute ischemic stroke. TPA became the gold standard of treatment. However, few were receiving this medication due to the time constraints for administration. TPA has to be administered within 3 hours of the patient's last known well time. In order to administer, we have to be sure that the patient is in fact having an ischemic stroke and not a hemorrhagic stroke or any stroke mimics taking place. And the diagnostic tool for that is a head CT. So this article here is simple in how to resort to CT time in acute stroke is a hospital based in Iran, and they recognized where their shortcomings were for meeting the TPA time frame, and so they worked on creating a one-call stroke system, and creating patient prioritization for CT and lab, and basically making sure that continuing education was a priority. The results of this was a decreased time for door to CT less than 20 minutes and a decreased time of door to needle time or TP administration of 55 minutes. So in this particular article, Michigan decided to utilize a qualitative study using audit and feedback to implement changes in their emergency department to meet the stroke protocol needs. A big thing was continuing education, making sure that nursing staff were aware of what the protocols were, who was responsible for what was taking place, and then changing where the TPA was located as opposed to having only in pharmacy, and pharmacists being in charge of mixing the medication and bringing it to the emergency room. It was made available within the med room in the ED, and nurses were trained on how to mix. Recommendations for establishing stroke systems of care. This is a 2019 update. This put emphasis on the burden of stroke, including those who are greater than 45, at a lower income, lower educated individuals who were more often to report signs and symptoms of stroke. African Americans and Hispanics are also more likely to report stroke symptoms than Caucasians. Strokes occurring every 40 seconds to an individual in the U.S. Death due to stroke every 4 minutes, making it the number 5 leading cause of death and the number 1 leading cause of disability. The cost of complications is $66.3 billion annually. Set forth the stroke system recommendations. So we want to get the stakeholders involved and give them these facts. We want to utilize community resources, including getting EMS personnel and educators out there, let them know how important it is for pre-hospital notification, enforce that pre-hospital notification protocol, and instill the importance of stroke protocols within the ED, including meeting DTC and DTN timeframes. So this article, Decreasing Stroke Codes, presenting with stroke symptoms, evidence-based practice quality improvement was put in to decrease their DTC time to less than 15 minutes. That was done with the goal of ensuring the standard guidelines of less than 25 minutes will be met more often. They put emphasis on the importance of DTC timing, as a decrease in CT is a decreased time in door-to-needle time. Time is brain. Meeting the guidelines is necessary to achieve stroke accreditation. So that was what this hospital was looking for, was that achievement. So the implementations that they put in place was they stopped putting the patient in a room before they went to CT. They stayed on the EMS gurney. That stretcher went straight to CT, and then they had the patient stretcher bed from the hospital itself waiting to be transferred from CT onto that so that the EMS could get their gurney back. EKG was only done if necessary. They stopped placing IV in. IV could be done either while the patient was waiting to come off of the CT table, or if the CT was still warming up, then they would go ahead and place the IV. So they did a lot of encouraging of multitasking. Barriers to achieving dual time. So the Helsinki model emphasis in this article, and their big thing was pre-hospital notification. So that includes immediate door to CT, bypassing the emergency department, which is what they did in this particular hospital. Pharmacy making TPA available within the ED, so that's kind of a pattern. Prior to evidence-based practice, pharmacy had the TPA, and a lot of these articles state the importance of putting TPA available for nurses. And then limiting the assessment time. The patient needs to be met at the door, take the patient straight to CT, and get the ball rolling. Analysis process for acute ischemic stroke in urban and rural hospitals in Nova Scotia. This one was really important to me because it gives comparison between rural hospitals and urban hospitals. I myself work in a rural hospital, and they just put emphasis on the fact that we need nursing staff and physicians to be comfortable with administration of TPA. We need that education to continue. A decrease comfort in staffing being comfortable with the administration meant that there was a decrease in administration of TPA. So plan of change, we want to implement education on stroke protocols. We want to make sure that a single system code stroke alert to those involved in each department. That's radiology, laboratory, obviously the physician, nursing staff, nursing supervisor, patient access, and this can be done with pre-hospital notification, quick activation code using Pulsera. So we have Pulsera for STEMI and for stroke. We push that button that lets our sister hospital know that we have a code stroke coming in. We're going to do all of the things that we need to on our end, and then we have transportation ready for them to go to a higher level of care. Here we can't have an actual code stroke team. We have resources for that, so each RN in the emergency department needs to know stroke protocols. Everybody's going to have a hand in the treatment of this patient. A lot of times we utilize our EMS personnel. We keep them here until our patient has been stabilized. But there's always a primary nurse, and then obviously the ED physician in the ambulance bay, perform a focused assessment, make sure the patient is stable enough to go to CT. We don't transfer stretchers. We need to take that patient straight from the ambulance bay over to the CT table. We can insert our IV and draw labs when it's appropriate while waiting for CT to be ready, or immediately after. We can have the TPA removed from the mix machine, have it ready mixed for when the CT results are read. Obviously, we're going to be ready for transfer for a higher level of care because we've utilized Pulsera. We need to get the stakeholders involved: staff, laboratory, pharmacy, radiology, EMS, community outreach programs. We need to teach the community what stroke prevention is, what the symptoms are of stroke. Utilizing Cotter and Cohen's model change, form a team. We need to set some goals and time frame, present the facts, present the positive outcomes, change, show positivity, and utilize a feedback loop. So, as we talked about before, Connor Cohen's model of change to address the barriers, we need to create clear and concise plan for protocol implementation, bringing a team members from each discipline involved, providing positive feedback. Positive patient outcomes: for every 15 minutes decrease in administration time of TPA increases in positive outcome for the patient by 4%. Internal evidence would be quality improvement, protocols understood, reports of nursing staff comfortable and confident in administering TPA. Also, would be increase in door to CT time and door to kneel time. So, evaluation is going to be a seamless protocol implementation. We're going to meet the patient at the ambulance door, or if patient access has a patient in the lobby, we're going to have them make sure that they hit that staff assistance required button. We're going to wheel that in after a focused assessment. We're going to make sure that Winchester Medical Center is aware that we're going to be alerting them for transport as soon as our patient is stabilized. We're going to meet the time frame of both DTC and DTN times. And our ethical considerations are going to be when we're implementing these protocols. We want to make sure that we're not tripping over our feet trying to make sure that these protocols are being met step by step. While EBP implementation does not require informed consent, we do need to remember that the administration of TPA itself in most instances does require consent. And then we need to ensure that staff knowledge of prior to implementation is absolutely complete. So decreasing DCT time means we're going to decrease our time for administration for TPA. It's got to be administered in a timely basis within 60 minutes of arrival time, 3 hours of last time. Connor Cohen's model for change will assist in making protocol implementation easier to follow. We're going to make a significant change to implement will be to meet patient and EMS at the ambulance bay, transfer patient straight to CT, as opposed to transfer from EMS stretcher to ED stretcher and then rooming the patient prior to CT. Education on patient access and registration on the symptoms of possible stroke so that they can activate that staff assistance required alarm to alert nursing staff if there's a patient